The information shared on the Allo podcast is not intended as medical advice. Your medical care decisions should be made in consultation with your physician who is familiar with your specific case.
Hi, welcome to the Allo podcast from the Allo Hope Foundation. I'm Bethany Weathersby.
And I'm Molly Sherwood.
And I'm Katie Shanahan here with my best friends to discuss a topic that's incredibly meaningful to me.
Yes, Katie lives and breathes Rh prevention. If the world was run by Katie, there would be no Rh disease, I think.
Katie, you tell us what the topic is, and then I'll chatter.
Our topic today is going to be Rh Immune Globulin and all about it. How it was developed, what it does, all the controversy around it. Funny story, my husband and I were playing like a questions game to get to know each other better. And
wait, when you were dating or
like
recently?
Lately?
No, like recently.
Okay.
You know, to like rekindle our marriage.
All right. Yeah, that's good.
And one of the questions was like, if you had to give a TED Talk, what would you give a TED Talk about? And I immediately was like, RhoGAM.
Yep.
100% immediately. So
was he surprised at all by that answer?
No. He was like, I feel like I knew you were going to say that.
Our goal for today's podcast is to present the facts about Rh Immune Globulin, which in America, at least, is commonly referred to by the trade name RhoGAM, but there's some other trade names too. But we're going to talk about what it is, why it's important, how it works, and then we're going to address the problems and controversies about using it and when to use it kind of head on, even though none of us are very good at healthy confrontation. Are we? Maybe we are. We actually have pretty strong convictions, but we also hate confronting people. So it's like a really, really hard line.
Yeah, it's a struggle. Go ahead.
I feel like we're pretty good about confronting each other, but otherwise we're just like have it written all over our face and have to tell each other to fix our
Katie has a serious stank face. Like if she is not into something that's being said, we have to be like, Katie, fix your face. Everyone's going to see.
I do. I really do.
Oh my gosh. So let's talk about what it is. What is Rh Immune Globulin? How does it work? And all that good stuff. So Rh Immune Globulin is also called RhoGAM or RhIG. Sometimes we just call it RhIG. Anti-D injection, WinRho, and there's lots of other names for it. And it's a medication used to prevent women who are Rh negative, so women with a negative blood type, from becoming sensitized, which just means developing anti-D antibodies.
And quick review, women become sensitized after they're exposed to a blood type that's different from their own. And their immune system responds by creating antibodies to destroy that specific blood type. And once you have antibodies, you'll have them for the rest of your life. There's no going back. So we really want to get there first and prevent that from happening. Sometimes we can prevent a woman from being exposed to foreign blood in the first place by giving her only Rh negative blood products during a transfusion. But sometimes we can't prevent a woman's exposure to a foreign blood type, especially during pregnancy. But with this medication, the goal is to prevent her immune system from creating the antibodies in response to that foreign blood exposure.
Yeah, that's a good reminder. All of this can be kind of complex and confusing. So that was good to just go back to what that means. And then honestly, I think this is so fascinating to think about how this works. Okay, so the medication is actually created from human blood plasma, and it's made up of other people's anti-D antibodies, which is crazy because we're trying to avoid anti-D antibodies, right? So why in the world would we inject a woman with a little bit of anti-D antibodies? And it's actually genius. Okay, so imagine with me, come into my picture world. Okay, that we are all
picture world.
We're soldiers. Okay, we are the immune system, and we are patrolling. Sorry. Occasionally I just throw some like inappropriate words in to kind of spice things up when we're going through the script. And so, yeah, we are patrolling hardcore this human body, okay? And we are in this human body, we're patrolling, we're ready to destroy and kill any cell that looks suspicious to us. And we do a lot of profiling, guys. Okay, that's not appropriate, but anything that looks suspicious. And so we have an insanely well-stocked weapon arsenal that's ready to go. And we have in there the perfect weapons to destroy whatever cell we come across. So invading flu virus, we have a weapon for that. It's called flu antibodies. And, infection, we have a weapon for that. So imagine that there is now an all new invader. Okay, this is a cell we have never seen before, and we search out the weapon arsenal for the perfect weapon. We can't find it, so we're losing our minds. Right? We are very uptight about this, and so we're starting to freak out. So, how are we going to kill this invader? Right? And we don't have a weapon for it. What are we going to do? And so, let me just clarify. The invader here is actually foreign blood type, actually. And we don't know what it is. And we are just assuming that it's something dangerous. So the commander is just about to make the call for all hands on deck. We've got to create a new weapon called anti-D antibodies to keep the arsenal well stocked for this invader. And once we create that weapon, it stays in the weapon arsenal forever. Okay. So now suddenly I just became the commander. Okay. I'm about to make the call that we need this new weapon. And suddenly one of the soldiers is like, hey guys, look what I found in the back of the warehouse. It's anti-D antibodies. And then you guys cheer with me. We're all cheering. And we suddenly feel so safe because, we do actually have that weapon. And we don't have to create the weapon. Okay. That was just a false alarm. And so then we just chill. We're not freaking out. We're not going to make any new weapons because we already have it way in the back of our warehouse. Okay. So then we just stand down. Everybody go relax. And so now let's step back into reality, okay? Into
non-commander.
Step back into an adult brain, okay? And so when a woman is Rh negative and she receives the RhoGAM injection or the RhIG injection, she's getting a tiny bit of anti-D antibodies that are passive. And those antibodies trick that woman's immune system into thinking that, she already produced antibodies. We already have the weapon against the foreign invader, which is a blood type that is different from her own, a positive, antigen positive blood type. Okay. And so then it kind of gives the message to the immune system, there's no need to make anti-D antibodies. And that's what prevents the creation of anti-D antibodies. And then actually those injected antibody, the tiny bit in RhoGAM, will actually just kind of float around the body for a bit and then die off. And they are not harmful. I hope that makes sense.
Wow.
Yeah.
It does. It really does. But that was quite the ride that you just took us on. But I love it. I love it. So you're basically...
Welcome to my brain.
I have a full visual. I feel like I'm in there's a SpongeBob episode where they went inside of SpongeBob's brain, except it was kind of empty because he's a sponge. But
that was funny. There was nothing in there. Is that what you're saying? What are you trying to say, Molly?
I feel like I went inside of your brain. I was transported with you.
Yeah.
That was so good because
I
think there's a lot of confusion about why are you giving me antibodies to prevent me from developing antibodies? But that was the perfect way of laying it out. And so I want to talk through the fact that we are injecting the very thing into the body that we are trying to avoid. How is that possibly safe? Well, the amount of antibodies is so small, it can't actually do any damage. And like you said, the antibodies eventually die off because your body's not creating new ones continuously like they would if they had developed their own antibody arsenal. Like you said, they already have something in storage. It's here's a little bit of something we can use right now. And it's not triggering anything for the body to start creating their own antibodies.
I think we should definitely talk about how it was discovered and created. But before we do that, we really have to go back even further and look at the world before Rh Immune Globulin. Like, what did alloimmunization look like in a world before this medication? So prior to its invention, HDFN actually caused about 10,000 deaths a year in the United States alone. And I think they averaged like 25,000 cases of neurological damage. Was that the stat, Molly, that I sent you?
That's so bad.
I know. And the neurological damage happened from kernicterus, which is permanent brain damage from high bilirubin levels. And the alloimmunization rate before RhIG was actually 17 to 20%, which is extremely high and not rare at all, like we think of it today. Just for comparison, and this is super interesting, the worst year of polio that the U.S. ever had resulted in 3,000 deaths from polio. So we're talking 3 times that much. And then whooping cough before vaccines caused about 9,000 deaths per year. So again, very similar death rates. So just like really destructive and devastating disease. Reports of moms losing 7 babies, stillbirths, miscarriages. So many families were devastated by this disease before the invention of this medication. So there really was a drive to find a cure for sure. So I'm going to name a few of the like key players who are like heroes in all of our books, I think, and like totally nerd out. So the first is Vincent Freda. He was an obstetrician at Columbia, and he was deeply affected by the deaths he was seeing due to HDFN. And the director at the blood bank there at Columbia, Dr. John Gorman, was also very concerned about the problem. So they teamed up to start researching possible solutions, and they really together came up with the idea. And then it was later tested on 600 Rh negative women in clinical trials, and then approved in 1968 by the FDA. Before it was invented, the alloimmunization rate was 17 to 20%, and it reduced it to 0.5 to 1.8%. And then when they added in the additional antepartum dose, so the dose that most women get at 28 weeks, this further reduced the alloimmunization rate to 0.14 to 0.2%. Like, that's amazing.
Wow.
Huge.
That's incredible. Wow.
Yeah. And because of their invention, Rh negative women in developed countries are almost guaranteed disease-free pregnancies. It's just amazing.
Wow. It really is. I think back then it was this incredible new discovery, and now it's just routine, right? And I think that we miss the miracle of it, you know?
Do you guys have...
Go ahead.
I feel like a lot of times when we have a speaking engagement or something, people come up to... This just happened to me last week. Someone came up to me afterwards and said, oh, my grandmother had this, you know, or my uncle. Someone just told me that their uncle did survive HDFN, but was severely brain damaged. And then the grandmother wasn't able to have living children after that. So I hear a lot of times people in older generations or who have that connectedness with generations a couple years back do still have those memories, but it's definitely dwindling. I mean, people in our generation certainly don't have that lived experience of knowing somebody, usually, that could have benefited from RhoGAM.
True.
Yeah, it's definitely like the older generations that seem to understand its importance and actually understand the disease a little bit more, at least with people I've talked to in those types of settings.
Yeah. And can you imagine not having birth control and then not having any type of prevention or treatment at all? And so you were just like at the mercy of this disease.
At the same time that they were trying to develop this drug in Colombia, there were also 2 guys in England, Cyril Clarke and Ronald Finn, and then Alvin Zapersky that was working in Canada, all on the same stuff. And so these people like really deeply cared about creating a better world.
All right, let's talk about the safety and efficacy of the medication. So I would be happy to talk about this because I just refreshed my knowledge by rereading the drug label today, which is by the way,
my gosh.
does anybody know you can do that on any of your medications? Like when you open up the little box, there's this like very folded up, crinkled thing that you open up, and that's the whole drug label. And that'll go through, most of the clinical trials that have been done and how it's absorbed in the body and side effects and all those things. You can read that for yourself, like whenever you want. So if anyone is curious, just look up the drug label for RhoGAM or WinRho or whatever. But it's given by intramuscular injection usually. And so have you guys ever gotten it? Only you got it, Katie. It kind of goes like around your butt, hip, thigh area, usually. And sometimes it's given IV, but that's usually reserved for cases where there's been like a significant exchange of blood between the mom and baby. And like Bethany and Katie, you both said, it has been shown consistently in clinical trials to be 99 to 100% effective in preventing women from developing anti-D antibodies during their pregnancies. And the most common side effects, I know, which is huge. That's
amazing.
That's great.
It's incredible.
Yeah. And the most common side effects are also relatively mild, like swelling, pain, or redness at the site, and less frequently like an elevated body temperature. And to quickly explain adverse events and how they are reported, every company who markets a drug is obligated by the FDA or whatever regulatory body to constantly monitor and collect safety reporting information. So they are always required to collect and report continuously. And if anything kind of flares up and looks abnormal for any reason, they're required to submit it within 24 hours. And there's a bunch of mitigation processes that go on if that were to happen. And so this is always continuously monitored after it's on the market. And that's true for any medication. And so the RhoGAM or Rh Immune Globulin, when it's administered at 28 weeks and as well as within 72 hours after delivery, it's been shown to reduce that Rh immunization rate to about 0.1 to 0.2%. And I also looked at some of the safety data, and to date, there has never been a death due to the administration of this drug for pregnancy or bleeding. And the plasma donors that are used to make this drug, because like we talked about, it's made of a bunch of human plasma kind of brought together. It's heavily screened, and the cleaning process is super tightly regulated. So it's screened for hepatitis B and C, HIV, HCV, and it also goes through this special like viral reduction process and cleaning to clean and inactivate any remaining virus cells that are in the plasma donation. And this is like so tightly regulated, and there has never been any case of viral transmission or infectious disease transfer with this medication. So I just want to put that out there because I think those are some of the concerns people might have when they're thinking about taking something that, because it's an injection, the immediate association is, oh, this is a vaccine. It's actually not. It's a medication.
Okay, so let's look at how RhIG or RhoGAM or whatever we're going to call it, Rh Immune Globulin, is actually made. And to make this medication, it seems like they would need a lot of anti-D antibodies, right, to make this medication for this many people, because a lot of people need this. And where would they even get all those anti-D antibodies to make this?
Well, I'm glad you asked.
Yeah.
I feel like I need Molly's like big glasses for this podcast to wear.
Oh, I love it.
Should I bring my glasses out?
Maybe.
Oh, yes.
You should introduce them.
I feel so happy when your glasses are on. It's Late Nights with Molly Sherwood.
Yeah.
Oh,
That's
anyway, I don't know about
my nighttime glasses.
All right. Well, I have another history lesson waiting for everyone. Moving on from Late Nights with Molly Sherwood.
All are welcome.
Sorry. Well, can we just say Late Nights with Molly? Look, let me just tell you what we do late nights, okay? We nerd out to research and like data. That's what we do late at night on Marco Polo, and she gets her glasses on, and it's fantastic. So it sounded dirty.
I know. Our poor spouses.
Oh, my spouse sleeps like a rock.
Yeah.
Like I carry on. He'll be like in the periph background, just completely unconscious while I carry on with my polos for as long as I want.
She doesn't talk quietly. She just says what she wants. And he just keeps sleeping. It's great.
Sometimes he'll wake up though and just like roll his eyes at her and then go back to sleep.
Yeah. Okay, so anyway, middays with Katie Shanahan. Let's go. Okay. Tell us how they make this.
Well, I'm gonna start with one person in particular, who is James Harrison. He's considered the man with the golden arm. So this guy. Are you laughing at my nerding?
Sorry, I just wanted to make a joke and correct your pronunciation of James and be like, I believe it's pronounced Hems.
Hummus.
Oh my gosh. You should have, because I would have been mortified. Okay. All right. So we're going to start with one person. His name is James Harrison. He's quote unquote the man with the golden arm. So this guy had a major chest surgery when he was 14 years old. He got tons of blood, tons and tons of units of blood in the surgery. They thought he was going to die, but he survived. And he decided to become a blood donor shortly after that to give back, and started donating in the 50s. Are you guys laughing at me, nerd?
No, I just can't. I can't. No, Molly.
It's me. I'm the problem. I'm just having the giggles.
I am too. And you also said blood by accident. Just, right. I don't know. Okay, we gotta.
I'm sorry, guys.
We gotta
keep
mature.
This in because I feel so bad for the editing you guys have to do. It's fine. We'll just have to suffer the consequences of being 10-year-olds.
Okay.
All right. Okay, so he started donating blood in the 50s, and a few years later, it was discovered he had anti-D antibodies that could be used to create RhoGAM. So he switched over to plasma donations and was one of the founding members of New South Wales. So this is Australia, their RH program in the late 60s. So get this, he made 1,173 plasma donations for the anti-D program, and donated until he turned 81, which was the age that he had to stop. So he donated from 1969 to 2018. And
that's insane.
Isn't that incredible? This guy is so awesome.
Oh my gosh.
So every batch of anti-D that's ever been made in Australia came from his blood. And even his daughters benefited from his donations. So
Is that...
Wow.
Okay, go ahead. Sorry.
His daughters got RhoGAM
because they were probably Rh negative.
Yeah.
Oh my gosh.
Yeah.
Is that really true is it still all of the doses in Australia?
That's what it says.
Are still from his blood? Oh, okay. Well,
maybe not
so
still,
I wonder,
but
because he stopped donating until 2018. Wow.
Yeah. And then there's also some other really cool people. So other women who had multiple losses. Olive Semler was from Australia. She lost 7 babies, and after Australia started their RH program, she made 500 donations. Same with RH Ladies of Winnipeg in Canada. It was 21 women who spent hours weekly donating plasma, and it was enough to supply all of Canada. And some of them also had 7 pregnancy losses, which is just so incredible.
Wow.
I bet that felt
amazing.
And you know what? Like a support group kind of for them.
Yeah.
In a way.
Yeah.
Oh my goodness.
I think a lot of women in our support group are craving that opportunity to do something good with their antibodies,
Yeah, for sure.
Yeah.
And also, when I hear you sharing that one person can supply the RhoGAM for an entire country, that is it creates so much hope for me, because it's it is possible. When you do donate, that is a huge impact. That is creating so many doses. Any one donation is so, so valuable.
Yeah.
So only people who are Rh negative can make the anti-D antibody, but there are essentially two groups of pools of potential donors. So one is volunteers, and they have to be Rh negative, and they're given an injection containing the D antigen. And it's in order to try to basically sensitize them so that their immune system starts producing antibodies. And then they'll boost with smaller injections to get the antibody levels up high enough to qualify for a donation. Obviously, this is reserved for people who aren't at risk for having a pregnancy complicated with HDFN, like women who are sterile or men who are not going to become pregnant, obviously. So that's the first potential donor pool. And the other is wonderful selfless donors like James and like those women that you just spoke about, Katie, who have anti-D antibodies naturally or because they, went through these pregnancies and developed antibodies, and they want to protect future mothers from the tragedies that they have experienced. And we actually have one of those selfless donors right here with us on the podcast.
Oh.
Katie just recently flew to donate her own plasma with anti-D antibodies that is being used to create RhoGAM, which will help protect other mothers and babies from going through the type of pregnancy and NICU trauma that she and Liam had to go through, which is incredible.
Amazing.
So is there anything you want to share? It's so wonderful.
Yeah.
What do you want to share about your experience donating or why you chose to do that?
I don't know. It was a lot more emotional than I thought it was going to be. It was very, very emotional. And I just really felt this very strong conviction to help prevent what my family went through. I know a lot of people are familiar with my story, but I became sensitized because I didn't receive Rh Immune Globulin when I should have. And so it just kind of gives our pain some purpose to know that I'm playing a part in hopefully someone not experiencing the same thing we did. And I don't think people realize how important it is because they weren't around prior to the 60s when it wasn't available and it was so prevalent. And the rarity of the disease and the cure, right, has created its own obstacle because people don't really understand the consequences of HDFN, but our families do, right? We've dealt with those consequences. And so it's really hard for me personally to see all the ways women aren't benefiting from this miracle cure, either by choice or because they don't have access.
Yeah, totally agree. I've struggled with this too over the years because, as our listeners know, my daughter died from HDFN, and then my other babies had to go through so much to get here alive. And it's hard for me to fathom even just having the ability to prevent the worst thing that has ever happened to me. It gives me goosebumps thinking that some people are actually they have the option to prevent this disease and to keep their children safe from this and to protect their own mental, emotional health, and kind of keep themselves intact in that way. They have the option. And I did want to also say that this preventative medication is only available for one of these red cell antibodies, okay, which is anti-D, and there's many, many others, right? And those other antibodies, there is no injection. There's no preventative medication. It's just this one. And so in a way, and I know that most women who have a negative blood type don't feel this way probably, but in a way, from my perspective, they are incredibly privileged. Especially if they have affordable access to Rh Immune Globulin, RhoGAM, and you have the opportunity to receive it on time and prevent this terrible disease. That's my dream. And I just wish that could have been the case for us. And so I hope that Yeah, I wish that women would really take advantage of it. And I guess just feel that the weight of the opportunity that they are being given. Okay, I think this is kind of the perfect lead into our section on controversy, right? Because this is a huge part of this topic. This discussion is there's a lot of strong feelings surrounding this. People have very strong convictions, and let's talk about them. That's what we're here for. Okay, so if this medication really does work 99% of the time, 99 to 100% of the time to prevent sensitization, then why isn't Rh disease mostly eradicated by now? It should be by now, if that's true. And I think the answers to that question seem to be at the heart of the controversy. There's lots of different controversial points, and I feel like almost all of them could be an answer to the question, why isn't this disease eradicated right now?
Yeah.
So let's talk about it.
Yeah, I think that is true. And I'll list, there's a multitude of reasons why some women who need this don't get it. First of all, there is a global shortage, and there's also a shortage even in the US. There's not enough to go around, and people even in the US are starting to stockpile it at their centers and having to make difficult choices about who gets it and who doesn't get it. But not only is that the situation in developed countries, but it's also not accessible in developing nations to either people who can't afford it, or it's not an option where they live whatsoever. Or we'll get to this later, but there's another product that's a monoclonal version of this drug, and that's the only thing that's available in some of these countries and at astronomical prices, and we don't even know if it works. There's also confusion about the protocol for when to administer it. You know, do we give it in the first trimester or not? Do we give it another time if we already gave it earlier for bleeding? So there's some ambiguity there. And then, of course, there's unfortunately some discourse around refusal to accept it because it's sort of grouped in with vaccines. Even though it's not a vaccine, like we talked about, there's this kind of small subculture of women who have joined and read about this RhoGAM rebellion concept. And there's a lot of rumors, lots of things online. And then there's just growing vaccine hesitancy that's happened in developed countries, but especially in America over the last few years. And so I think that also gets tied in with this sort of misinformation about the disease in general, because people don't realize the consequences. And it causes not only women, but also the people providing their care to forget to give the dose because we're so detached. Many people are so detached from the consequences of not getting it that doses are missed.
Yeah, and I think that actually really is a good segue into like, why isn't there enough to go around? And I think one of the main reasons is people don't understand what the consequences are of HDFN, and they don't understand that you need a continuous, sustained process of plasma donors to create this medication. And so the donor pool is decreasing. And I think if you talk to most specialty plasma centers, they'll say that things changed dramatically after COVID. And there's just been decreased donor pools since then. So specifically, there is a big RhoGAM shortage. The FDA announced it in January or February of 2024, so this year. And we heard from several physicians that they were getting calls, MFMs were getting calls on, we have one dose of RhoGAM left. How do we prioritize our patients? And so ACOG actually, so the American College of Obstetrics and Gynecologists, released a practice bulletin to triage the shortage and offered a couple prioritization and conservation strategies for consideration. So the first one was to avoid giving RhIG in sensitized patients, which we know that that's an indication not to give Rh Immune Globulin, but it's actually not well known. And I think if you remember earlier on, you asked if I've ever received RhoGAM. And I didn't receive it when I needed it, but then I bled during my pregnancy, already had anti-D antibodies, and it was given to me. So that's kind of just a wasted dose at that point. If your partner's Rh negative, also don't need RhoGAM. You would think that these types of things were common sense, but it really happens all the time. Some people started prioritizing postpartum patients over patients getting the 28-week dose because that's the more effective dose. And then something that's really coming about is utilizing cell-free fetal DNA to determine fetal RhD status. So this is something they actually do in some other countries, including the Netherlands, where they utilize cell-free fetal DNA to determine the fetal RhD status. And if the fetus is RhD negative, they don't give Rh Immune Globulin, which is actually a really great idea and could conserve a lot of doses. So 40% of RhD negative pregnant women will carry a negative fetus. So you can imagine how many doses of Rh Immune Globulin that would save. And it's a question now, like, should this be the standard of care now that cell-free fetal DNA has been shown to be so effective?
I also want to talk about the global shortage. And this is another controversial topic and one that's very close to our hearts because about 50% of the world's population who needs RhoGAM or RhIG don't receive it. And so that's an estimated 3 million women annually who don't receive prevention when they need it. And a lot of these countries are low income countries or developing nations, and a lot of them do not have the resources that we have. They don't have the treatment options for women who do become sensitized. And it's just a horrific disease in these developing countries. And actually, when we were describing what did the world look like before RhoGAM here in the U.S., it made me think of what we have seen in Kenya and what we've seen in other surrounding countries in Africa. Because those women are, that is their reality. They're losing some of them are losing 5, 6, 7 babies, and they don't have access to the prevention that they should. And I think they need that prevention piece is even more crucial to the women who don't have any treatment options, right? And so it's heartbreaking, and it's something that we care about deeply, and we really want to help find a solution to. Okay, so right now there's still about 160,000 deaths happening annually caused by HDFN around the world, and estimated 100,000 disabilities. And these we're going to put our sources at the end or in the show notes. But this is from Figo and Wire, and we'll put that in the show notes. But we don't even fully know the true burden of this disease in Africa because there's such an absence of population-based data. And but just from what we know and what we've seen and what patients have told us, I think it's an incredibly serious disease that is devastating families. And this preventative medication, this Rh Immune Globulin, has definitely decreased the rates of alloimmunization in developed countries like ours. And I don't know what if it has in these other countries that don't have access to it. And it's actually pretty much non-existent in Russia. Think about how many people live in Russia. China, right? And we kind of talked about some of this in our Around the World episode. But, South America, some parts, they just don't have access to it, or they have to purchase it on their own. And it's incredibly expensive for these people, especially people who are living in poverty or who are focused on, how am I going to feed my children their next meal? They can't take money out of that their pocket for something like this. And so it's estimated that $150 million a year is needed to completely solve this problem. All right. And so it's a lot of money. Sure. That's a lot of money. But in the grand scheme of things, honestly, if we could all truly see the absolute devastation that this disease causes globally, that seems like a great deal. $150 million to solve the problem. And so, it's minimal. It's minimal. And if you think about how much money is spent on public health, in some countries, like if we just took a portion of that and put it towards this problem, we could save so many lives and save so many families from being impacted in the way that they are. Okay, I'm stepping off my high horse here.
That was beautiful.
Well,
No, that wasn't a high horse. It was a
it's been
soapbox.
Well,
It was
yeah,
lovely.
I just feel so strongly about it.
I like it on your
okay,
soapbox.
All right.
It's been 60 years since it was
Right.
developed. Like, it's time.
Sure.
It's time for it to be
Yeah,
in
it's-
other countries.
It's just not talked about enough compared to some other public health issues around the world, considering its prevalence still. We don't talk about it enough. And I was going to talk about this concept of developing a monoclonal product, which would be great because a monoclonal product is like a synthetic cell line that you can grow in a lab and then use it to make as much RhoGAM or whatever you would call it as you need. But that has yet to be played out in a way that has been demonstrated to be safe and effective. And even though there are continued attempts to do so, and there actually is one approved monoclonal product in India, it's called RhoClone. But interestingly, it's not approved for the FDA and the EMA in Europe. And that's because there's limited data to support that it even works. And so there are two we don't want to go into, I won't go to too many details, but there's been 2 trials on it that have some major flaws in terms of figuring out if it's actually working. And you know how I talked about, for us in the US, when something is on the market, there's a lot of ongoing monitoring and reporting to make sure that it's safe and that it's working. That's not happening with this. And that is the product that these women in sub-Saharan Africa and some other underserved countries, that is for many countries the only product they can get if they do manage to scrounge together enough to afford it. And so it's the only formulation available to them, but it still costs $75 to $100, which is sometimes half or even all of monthly income for somebody who might live in Kenya or elsewhere nearby. And we know women ourselves who have become sensitized, even though they did everything they could to get this product. And this is the only thing that was available to them.
So can I just go take a couple steps back and just clarify a few things? Okay. So right now, Rh Immune Globulin is made up of lots of people's anti-D antibodies kind of pulled together into the product and then cleaned and, and then it is, sanitized and cleaned and then created into this solution. Okay. So that is actually called a polyclonal antibody. And it comes from lots of different people and it comes from their plasma. And so far, that's the only way that has been clinically proven to create effective Rh Immune Globulin. Okay. Polyclonal from humans, plasma. But like we've kind of mentioned, it's really hard to actually get people to come in and donate. And then I don't know if we mentioned this. I think we might have accidentally left it out. But the majority of the world's supply of Rh Immune Globulin comes from U.S. plasma donors, actually, because a lot of other countries don't have legally you can't collect plasma for some certain reasons, or you can't stimulate someone's immune system to become sensitized. Anyway, there's other rules and regulations. So most of the world's supply comes from plasma donors in the US, but there's only so many of us. And so all this to say, it would be much easier and quicker and probably cost effective to just be able to create the anti-D antibody in a lab, or come up with a way to make it so that we don't have to take people's plasma, right? A lot of people's plasma. And that's what we're talking about when we say monoclonal antibody. It's like the man-made version where you're not having to take plasma from all these different donors. So that's what we're talking about with monoclonal. And, but yeah, like Molly said, we don't have good evidence yet for the monoclonal antibodies that are out there to show that they are effective, like RhoGAM or other polyclonal. And so that's what we're talking about in these countries in Africa. They only have access to the monoclonal version that we don't even know if it works. And then they have to pay so much money to get that version that we don't even know if it works. Sorry, Molly, I just stepped in, but it's confusing. And I only recently learned all of this. So that's why I just want to put it out there if that can clarify what we're talking about.
Yeah, I think that's helpful.
I also wanted to add too that like there's a lot of confusion about polyclonal versus monoclonal. And we do know women in Africa that have received this monoclonal version and have still gone on to become sensitized. But we have talked to like our medical advisory board, and they do feel like them receiving some sort of prevention is better than nothing. And so you might see us advocating for fundraising for Rh Immune Globulin doses for Africa. And we've kind of taken a stance that some prevention is better than none. And so while we don't know if it's effective, we've been told that we should try to get it to them so they at least have something. But I think ideally, we would love to get a plasma-derived product to them. Okay, so moving on to another controversial topic. There is a lot of disagreement surrounding administration and first trimester losses. So ACOG actually just released a new practice update. And for patients less than 12 weeks of gestation with abortion or pregnancy loss, ACOG is recommending foregoing routine Rh testing and routine prophylaxis. So they're basically saying, don't give RhoGAM in any loss less than 12 weeks. And then they go on to say it can be considered on an individual basis in the context of shared decision making regarding potential benefits and risks. I don't know. I have strong feelings about
before you tell the
this.
strong feelings, can you tell us really quick, what is the typical, I think we mentioned this earlier, but just remind us, when is it usually given during pregnancy?
Okay. All right. So like we kind of talked about before, RhoGAM's given at 28 weeks and within 72 hours after birth. Okay. We typically do it with any pregnancy bleeding. We would prefer it to be given with any loss, whether it's, first trimester, second trimester. Any sort of trauma like manual turning, any invasive procedure like an amnio or CVS. And so these new ACOG practice recommendations are following a trend. There's other organizations around the world, so like the WHO, the Society of Family Planning, that have also taken this stance to forego it in either induced abortion or miscarriage in the first trimester, so less than 12 weeks. And, I think from our perspective, we really like the SMFM recommendations, and that's typically what we defer to. So their thought is that the population level data that affirms that Rh immune globulin is unnecessary in the first trimester is unavailable. So we really don't know that it's unnecessary. And so it's better to prevent this devastating disease versus going off of information we don't have, right? So they go on to say in care settings in which testing and Rh immune globulin administration are logistically and financially feasible and do not hinder access to abortion care, they recommend both at spontaneous and induced abortion at less than 12 weeks of gestation.
And what is spontaneous abortion again?
Like a miscarriage. Yeah.
Yeah.
So it seems like a lot of organizations are really concerned about the state of affairs in the US and delaying or impeding access to abortion care. And of course, if that's a major concern, then, it could be potentially not administered. However, I think in most cases, we do believe it should be given just because there isn't that data to support not giving it. And the ACOG recommendations for me are really difficult because it talks about considering on an individual basis shared decision making regarding potential benefits
That
and
bothers
risks.
me.
But if you make this right, you're perpetuating inequity. Those those are less likely to have these shared decision making conversations, are more likely to not receive the prevention that they need, and then they're just going to go on to have issues in the future. And you're just perpetuating this idea of inequity. And so what really should be happening is these conversations should happen with everyone. This counseling should happen with everyone, and then women can make decisions how they want to go about doing this. But the costs and logistics of receiving a blood test and a medication are minimal compared to the costs and logistical considerations of managing an alloimmunized pregnancy.
Oh, yeah.
Right? Like, it just, I know that we're trying to minimize these concerns for women, and we should do that. If it's like really, truly a huge logistical concern or it impedes access to care, absolutely. But you're really setting women up for failure by not giving them everything they need at the forefront, you know?
Yeah. That's very interesting. Do you guys, I kind of just want to hear your opinion really quick on this. Do you think that it should be given in the first trimester with abortion or miscarriage or bleeding?
I mean, I think we all know my answer.
Molly?
Yeah.
What's your
No,
thoughts?
I do. But I really agree with what you said, Katie. I really disliked actually this whole but maybe you can give it in a shared decision-making model. Well, that's putting the onus on the patient to know what to ask for and to know all these things we just talked about and had to research ourselves for hours to help make that decision. And I don't like that. So I think what we need to be doing is allowing the practitioners to offer what we know and offer the recommendation and have a stance. And the patient always has a choice in what care they accept. And that's completely okay too. But we need to have a consistent way of saying, you know what? We don't know whether or not you're likely to become sensitized from this experience in your first trimester. And because there hasn't been enough proof to show that it's not going to happen, we're going to keep doing the safest thing. Here is what I would suggest. And then the patient can make that choice for herself with that knowledge.
Right. And I know I've seen many women in our group, our patient support group, who were sensitized in the first trimester. And I know a lot of times we can't tell exactly when, but for some women, it is very clear sometimes if they have been sensitized by a first trimester loss. Have you guys seen that in the group as well?
I haven't seen it super frequently, but I know of a couple stories of women who have had a miscarriage at less than 12 weeks and have gone on to become sensitized, for sure.
Yeah.
Okay. So I like what you were saying, Molly, about giving the information and tools for the woman to make the choice. And so that's going to lead into our next controversial topic, which I think is the biggest one. And this is refusing RhoGAM. So having access to it and choosing not to receive the RhoGAM or Rh Immune Globulin injection. And there's all kinds of stuff running rampant online, a lot of like rumors and myths, and like we mentioned before, vaccine hesitancy. And so, this is a growing trend that we have been watching for several years, actually, in our patient advocacy work. And it seems to really be gaining popularity, especially in the, like we said before, the non-vax or anti-vax. I don't even know anti-vax groups, or in patients who are just having some vaccine hesitancy. We have also noticed in our patient support group that seems to be an increasing number of allo-immunized women joining the support group after refusing the RhoGAM injection. And then we also have a growing number of women who reach out to us, and sometimes they ask to join the support group in order to see what happens if they refuse the RhoGAM shot. Does that make sense? We only allow allo-immunized women in the group, so they don't get to come and see that. But hopefully we'll kind of lay it out there today. And it's just women are, I feel like they're feeling pressure. They want information. Sometimes they don't actually know what the consequences would be if they got the shot or if they didn't get the shot, and they are questioning medications and interventions, and they're just trying to get to the truth and make the best decision, right?
Yeah. And some
Which
women,
we fully support.
Yes, totally. I think that's our obligation as, mothers or potential mothers,
Yeah.
And some women, actually, we've learned, I think this isn't terribly common, but it happens. They're feeling pressured to refuse the shot when it's offered, not necessarily by their medical provider, but sometimes other moms in their community. And we've even had a few women reach out whose doula or midwife pressured them into refusing it with the goal of a more natural pregnancy and childbirth experience, which we can come back to that specific concern later. And I want to mention that, I'm saying this, I don't know, but anyway, this is risky to say, but I myself have taken a lot of time when looking at vaccines for my children, because I just feel like, going with the flow while my child gets 15 shots in their childhood, I feel like I have a duty to look into that myself. And so I do that, of course. And I say that knowing I could get some flack for just like taking a moment to have a second thought. But I want to demonstrate that even as someone who really closely scrutinizes my own decisions about this, this is not one that I would ever forgo for many, many reasons. Firstly, it's not even a vaccine. It's a medication. And the side effect profile is really, really minimal. And it also has a short half-life, meaning that it's cleared from your body pretty quickly. Like 30 days is the half-life. That's not what you see with a vaccine. And this isn't something that is, this drug is not something that is preventing something that's otherwise quite unlikely to happen, like polio nowadays, of course, or something that is typically not very deadly, like chickenpox. This is something that carries like a 20% chance of me becoming sensitized if I don't get it. And the consequences of HDFN can be severe.
True. Yeah. Good points.
Thank you for sharing that, Molly, too, because I know that there is like a huge anti-vax trend, and people don't feel comfortable bringing up their opinions. And obviously, you're not anti-vax.
No,
but
and my kids
I think it's helpful for someone that.
Sorry.
Go ahead.
Oh my gosh.
I'm panicking about what I said, so I'm like, I have to defend what I said. But you're right.
No,
like,
I think
it feels scary to say.
I think it's perfect.
My kids all meet the state standards and everything, but I looked into everything, very much so.
I think that's a perfect description of what we really want to advocate for at the foundation, and why we felt like it was such an important topic to include in the season, because at Allo Hope Foundation, our goal is to give women all the information they need to make their own educated and informed decisions about their own healthcare and their baby's healthcare. And that's exactly what you're doing, Molly. It's in our Allo Hope guiding principles and values that make up our organization's infrastructure and shapes how we operate. Bethany included a quote from our credo and code of ethics, which I really want to share, that we are dedicated to ensuring that patients feel heard, respected, empowered, and supported with deliberate advocacy for underrepresented citizens and patients. And the Aloe Hope Foundation is loyal to patients above all other interested or affected parties. This is from our legal and medical ethics section. We promote patient choices, and women should be empowered to understand that they can make treatment choices. They can choose to get a second opinion. They can choose a different doctor. They can choose whether or not to pursue a larger family. So we just want to be really clear about who we work for first. It's the women and their babies. And I mean, this is Bethany's organization, but it's
the patients.
This.
It's for the patients. It's not mine.
It's the patients. You're right. Yeah. It's created by allo-immunized patients for patients, and it's run by patients. And I can attest that Bethany drills it into us, reminds us on a regular basis that we can't make decisions for patients. We can't tell them what they have to do. We educate them and inform them, and we can share our own lived experiences with them. And then we have to allow them to make whatever decision they feel is best for themselves and their babies. And this is something I really have to remind myself of when we do have women trying to join the support group who are questioning whether or not they should get RhoGAM. And initially, it was really, really hard for me and really triggering for me. But now it's kind of like, hey, you know what? They're asking questions. They're trying to make informed decisions. Like, isn't that really, really great? And definitely changed my tune a little bit.
Yeah.
Yes, I can attest. Bethany always says, speak the truth in love. And I love that so much.
Let's talk about this controversy. And we have years worth of input from Rh negative women who have reached out to us. And we also have been researching why women might refuse RhoGAM. And we've done research on this like for years, not just for this podcast episode, because it's something that comes up often and that we are very invested in. And so here's just a list of some of the main arguments that women might have for refusing RhoGAM during pregnancy. Okay, so it's just medicine, science, technology, big pharma, greed, or money that's driving the RhoGAM agenda. Some people feel like the government or the medical system want to control patients and then make those decisions for them. So there's this pressure from these entities pressuring them, or they feel that way, into, taking the shot. So that's one reason.
But in this case, if they really wanted to make money, they would stop giving RhoGAM because sensitized pregnancies are so much more expensive and so lucrative financially for the medical system. It certainly would keep a lot of hospitals and fetal centers and medical centers in business.
That's true.
And also, there's like not a ton of money in plasma because we've been talking about the limitations to having a product that's created from human donations. It's a limited resource. And it can't be scaled and mass produced. Why do you think there's a RhoGAM shortage? If these plasma companies had as much reach and control as some people fear they do, there wouldn't be a shortage. Like, do you guys think there's ever going to be a shortage of statin medications or a Coca-Cola shortage? No, there is not. This is a different situation.
Okay. So statins for like high blood pressure. Is that right?
Cholesterol.
Yeah. Cholesterol.
Yeah.
Okay. Yeah. Good point, Molly. And I immediately just envision all the medical bills flowing into my home from my pregnancy, my HDFN pregnancies, and with my 3 living children, my 3 living HDFN babies. I literally had $1 million pregnancies. So we added it up. $1 million pregnancies. And that was, of course, before insurance coverage. But that is so much money to be had in the skipping RhoGAM business. So, I do want to quickly touch on something we mentioned earlier about that external pressure that we feel to make these decisions. And that, this pressure is a huge factor contributing to that hesitancy around RhoGAM. And as women, we are tired of it. Right, guys? Like, I'm tired of being undermined and controlled and told what I can and can't do. I think it's somewhat of a typical experience for women, and not necessarily about medical decisions, but just overall. I feel like at some point in your life, if you're a woman, you're going to experience that. And so I hate that so many women do feel pressured when it comes to this choice. And I hope that just what we lay out here today can make it really clear what is the right decision for them. And just wanted to remind everyone that legally we do have the right to refuse medically recommended treatment during pregnancy. So I went down the rabbit hole, guys, okay, preparing for this, and read through this fantastic ACOG recommendation kind of bulletin for this very topic when a pregnant woman refuses medical treatment or intervention during her pregnancy. And they just have some ethical recommendations for how to handle that situation. So we will put the link to that whole document in the show notes. And then for anyone who is refusing treatment, you can always point to that to kind of support your rights to choose what medical treatment you do accept. And so I just want to read a tiny portion from those regulations. It says, pregnancy is not an exception to the principle that a decisionally capable patient has the right to refuse treatment, even treatment needed to maintain life. Therefore, a decisionally capable pregnant woman's decision to refuse recommended medical or surgical interventions should be respected. Okay. So the choice is ours. And I think that it's incredibly important to remember that, yes, we have the right to refuse whatever is suggested by the physician. But in rejecting recommendations, we have a responsibility to truly understand why the treatment or the intervention is being recommended in the first place, and what the consequences are of refusing that treatment. And so I just feel like that should really be a part of that decision. And this information that is being used to make the decision, it should be evidence-based and should come from a reliable source and not just from, a wellness warrior from the internet.
I think Bethany, that's so true, because I feel like a lot of women that we talk to, it's just standard of care to offer RhoGAM, but not really talk about why.
Right.
And so you really don't know what it is until you don't receive it when you should, and you become sensitized, or you're alloimmunized and you understand the consequences of HDFN. Mm-hmm. Otherwise, I've talked to friends that are just like, I had no idea. Mm-hmm. And it's so true. Like, it really needs to be hammered home a little bit more about why it is so important. And that would hopefully help with some of the hesitancy surrounding it.
Yeah. I think there's just, it's like, okay, here's what you should get. This is your injection, sign the release or whatever, without actually sitting down and having a discussion with the patient about it. Yeah. Or without the woman actually having a discussion with the doctor about it and hearing that point of view as well. So, okay, so let's go on to the next reason why, the next controversial idea. And so this one is that we should just trust our bodies to know how to keep our babies safe. And, our bodies were these are just things that we've read on the internet. My body was created to make life and birth, and we can trust our body's natural rhythm and function to carry out those tasks without issues. And one of the things that I found online, this is just an example of some of the sources out there, and this is from a health and wellness coach, and she describes herself as a crunchy mom and a wellness warrior. So this is directly from her site. And she says, the importance of trusting women's bodies. Why are we making people doubt that their bodies can't do what God designed it to do? Specifically, why do we think that women's bodies, which were created to do the ultimate miracle, birth a child, are inferior and can't perform the tasks they were designed to do? The fact is, they can. It's just that medicine, science, technology, money, and greed have interfered with that mindset and muddled the truth. Your body can heal. Your body can give birth. Your body was meant to do these things. Unfortunately, man-made factors are inhibiting us from doing what it was designed to do. And this is just, again, one example of this whole, argument to refuse RhoGAM.
But what's really not true about this concept is the idea that we can just trust our bodies to not develop this disease. Then should we just trust our bodies to never get the flu or to never get cancer or to never die? Like, the truth is, before RhoGAM, women were losing babies over and over, and that was a way of life. So making a choice not to accept it is a choice to expose your body to the 20% chance of developing this disease if you're Rh negative and your baby is Rh positive.
Right. And it is purely biological, right? The whole process of this, there's nothing...
That's what I...
What?
I was just going to say the same thing.
Go ahead.
What she's saying is exactly the exact opposite of what this disease actually is.
Right.
Like, our bodies are attacking our babies. It's not keeping them safe. But at the same time, our bodies are doing exactly what God designed them to do in creating an immune response to a foreign antigen.
True.
So it's just like... I'm trying to remain as neutral
awesome.
as possible here, guys, but that one was tough.
Oh, man. Wouldn't it be nice? Can I just say, it would be so nice if I could just be like, hey, body, I'm handing it over to you.
Right?
And then nothing would go wrong. I mean, that's ideal, right?
It's ignorance. It's just
Well,
plain ignorance.
yeah.
Should I not say that?
I don't know. I mean, sometimes it does work out okay, So
Yeah.
okay.
All right. Well, here's another reason that people sometimes refuse RhoGAM. They want to have a natural pregnancy without medical intervention, which I can totally understand. The truth is, RhoGAM isn't actually a vaccine. It's a sterilized solution that contains passive anti-D antibodies. And if a woman chooses to skip this medication, she has a high possibility of becoming sensitized. And an alloimmunized pregnancy is actually one of the least natural pregnancies possible that you can have.
That is so
like
true.
Bethany, your pregnancies are a perfect example of how unnatural these pregnancies are.
Right. Yeah. Can I just run through what this disease entailed for me that was very not natural? And I just want to say ahead of time that we are not into like fear-based coercion or anything like that. And we've been hesitant to actually kind of speak up publicly about what does this disease truly look like for those who are considering skipping the RhoGAM injection, just because, we don't want it to feel like fear mongering or that type of coercion. But we do want to, like Molly said earlier, speak the truth in love. It is our job to show the world what this disease actually looks like, because then the women who are in this decision-making process will understand what they have a chance to avoid. And so, and I have an extreme case, but for me, I had many, many blood draws and blood tests, weekly ultrasounds, starting in the first trimester, for me, just because of my situation, but intrauterine blood transfusions. Okay, so that involves, medicating and temporarily paralyzing my baby in utero, giving me an IV sedative and painkiller, and then putting this large needle into my uterus, and then delivering blood products to my developing baby, right? And for me, it meant the death of my daughter, which is, mental and emotional pain and grief beyond comprehension. Stillbirth, the very act of giving birth to my baby who has no heartbeat. If you can try to imagine that process, it is the least natural thing I think I've ever done in my life. It's horrific. And then for my other babies to live, I had to have a permacath surgically placed using X-ray guidance into my jugular. And plasmapheresis. They take out my blood, run it through a machine, remove the plasma, and then return what's left of my blood into my body. And IVIG infusions every week, which is another human blood product. And that had horrible side effects for me. I couldn't stand up for longer than a couple of minutes at a time because I was so weak. And then surgery to remove the permacath. And then I had to have it put back in, another surgery, X-ray guidance again, because we realized, the baby does need that treatment again. And then surgery to remove it. And so many IUTs, so many serious medications. We had to temporarily move out of state for 5 months to find the correct medical care that we needed for my baby to survive. Medications like phenobarbital leading up to delivery to prevent hyperbilirubinemia and exchange transfusion post-birth. Anti-anxiety meds for me, early induction and not getting to go full term. And then my baby being whisked away immediately after birth to go have testing done. Before I get to breastfeed, before I get to snuggle my living baby who had just gone through so much with me to get here alive, and they have to whisk her away immediately. An emergency C-section with my next child, 3 weeks of NICU time. How unnatural is leaving the hospital without your baby, leaving your newborn in the care of other people that you don't even know? And that NICU life.
You can't even hold them. No skin to skin. They have to stay under those lights.
It's so bad.
So bad.
They're just laying, they have to have the phototherapy, but they're removed from me. And it's like their skin should be on my skin. They should be smelling me with every breath and having the warmth of us together. And yet they're in this like plastic bassinet and I can't feed him. I can't hold him. It was days before I was able to even attempt breastfeeding with my son, Callum. And then multiple blood transfusions for my baby. Blood draws every week on my newborn where the veins are too tiny for even the best phlebotomist. Is that what they're called, Katie? Or IV team to get in on the first stick. Multiple tries, and my baby is screaming for me and looking at me like, how could you do this to me? And that's every week, testing their blood until they were 15 weeks old. And I know I'm leaving a ton of stuff out, but yeah, it's a lot. It's not natural. And if you value a natural pregnancy, if you value going full term, delivering on your own terms, having control and say over your birth plan, if you value a home birth or whatever is the right choice for you, then I'm going to plead with you to please get your RhoGAM shot, because that is how you protect those very valuable things. And of course, if you value the health and safety of your child, then that is such a great way to protect them from all the things that I just listed.
Yeah, completely agree, Bethany.
Yeah,
we had a similar course, obviously not as thorough as you guys, but the best way truly to protect your natural pregnancy and have it be intervention free is to get RhoGAM. Mm-hmm. It just is.
Yeah. Oh. Mm-hmm. Okay. Sorry. I feel like I got on my soapbox again, guys, but I feel traumatized even just listing that stuff out.
Yeah, that was a lot.
I know.
I'm sorry, Katie. I'm sorry. That really came out of kind of nowhere, but I think that women deserve to know what they have the chance to avoid by getting this shot.
That was perfect.
Yeah.
That's perfect.
Okay, we have a couple of quick patient stories I just want to read as we finish up. We did ask some women who didn't receive RhoGAM, why didn't you receive RhoGAM? And one woman, P from the UK, she said, I didn't receive RhoGAM because during my first pregnancy, I already had antibodies before the shot was even given. Therefore, I was not given the shot because it would not work. So her medical team made the right decision there, because if you already have antibodies, there's no point in receiving RhoGAM. And then the other patient's story is from the US, and this is Alyssa. And she says, I did not receive RhoGAM because it wasn't given when it should have been. After a missed miscarriage at 14 weeks, I had a D&C and never received RhoGAM. After a failed procedure, I had a repeat D&C and still never got RhoGAM. I was not aware that I needed RhoGAM for a 14-week loss, although later I did see it was noted in my chart that I was supposed to receive it, and I didn't. During my next pregnancy, I was given incorrect information by my provider. I was told that I only needed RhoGAM at birth, and that if my baby had a positive blood type, even though we knew my husband had, at birth, and if my baby had a positive blood type. And we knew that my husband had a positive blood type. And so I didn't receive RhoGAM at 28 weeks or at all. And at some point during that pregnancy, I became sensitized and never knew until our daughter was stillborn full term as a result of untreated HDFN. So, very important.
Sorry. I'm trying to think of a way to respond.
Yeah.
But it's really hard. It's just so weird because there's so many people that are like, you need RhoGAM, you need RhoGAM, you need RhoGAM. And then there's people that just miss it completely. Yeah. And there's just no standard, and it just doesn't make any sense. And like these stories in particular, like Alyssa's, really resonates because that easily could have been me. Like,
right.
It's a very similar scenario. Yeah. And it just happened that my baby survived and hers didn't. And it's just not something that anyone should have to deal with at this point in time, this many years after the invention of this drug. It just shouldn't be happening.
Mm-hmm.
Yeah.
And I do think this speaks to, it is so rare. This disease is rare. So there's ignorance surrounding its importance. And
true,
we don't hear it that much because of RhoGAM, but people don't know that.
Let's talk about really quick while we're wrapping up some of the reasons why someone would not need RhoGAM during her pregnancy. So if someone has a positive blood type, if you're Rh positive, you don't need RhoGAM because you already have the D antigen in your blood. So it's not going to be foreign if your baby has it too. But if you are Rh negative and your baby is also Rh negative, then you also don't need RhoGAM. And we talked about ways to figure that out. So like if the paternity is certain and the dad has been tested and the dad is Rh negative, then you know you're good. Or also using cell-free DNA testing like the Unity screen can help us figure out if the baby that you're pregnant with is Rh negative or Rh positive. And so if they're Rh negative and you're Rh negative, you don't need to receive RhoGAM. Mm-hmm. Another reason that you shouldn't receive RhoGAM is if you are already alloimmunized, like Katie. You have anti-D antibodies. You should not receive RhoGAM again. That gets pushed a lot, though, weirdly enough. Also, to give a short voiceover about this, there are variations of being Rh positive or being Rh negative. Some women... some people have called a weak D phenotype, which means that just the genes that code for being Rh positive are weakly expressed, but they are still there. I have weak D. And so the literature and recommendations show that if you have weak D, you do not need to receive RhoGAM. But if you have partial D, which isn't the same as having weak D, it means that you express only part of the genes that make you Rh positive, you could still become sensitized. So if you have partial D, you still need RhoGAM. It's a very small, nuanced subpopulation. And so when it's in question, those women usually just go ahead and get RhoGAM.
Oh my gosh. I'm glad that you handled that because I don't know what that means. That last part, I can't. It's too much.
You're like, you lost me. I'm gone. Yeah.
Okay. All right. So let's end on a positive note. Okay. So how can we help? How can our listeners help? First of all, if you have antibodies already, especially anti-D antibodies, we can help refer you to a plasma donation center, and they can collect your antibodies and then pay you for your donation and use those antibodies to create Rh Immune Globulin or RhoGAM to protect other families from going through what you have been through. A company called Kedrion makes RhoGAM, and there are other companies that make other different formulations, and there's different brand names. But many other women with antibodies desperately want to use something terrible that happened to them, these antibodies, for good, turn it into helping others, and it changed the patient's life in a terrible way, but they can use it to change other families' lives in a really beautiful way. And so that is part of our job, is to help facilitate those connections, because we are dedicated to preventing HDFN. It's part of our mission. And also we're dedicated to supporting women throughout this whole process, before, during, and after pregnancy. And this can kind of help in that way if someone's interested in that.
We also maintain a small budget at Aloe Hope every month towards going towards paying for Rh Immune Globulin for women in Africa who can't afford it. Like we talked about before, it's not actually plasma-derived RhoGAM. It's a different product in Africa, but we still feel like it's important to have some form of prevention. Mm-hmm. And in some countries like Kenya, this medication costs 75 to 120 US dollars, which can be more than the average family makes in a month. It's really hard for us because we know that these patients are making decisions based off of, what they can afford for their families at that time. And of course, they're going to choose, the bare necessities over this medication. So we'll link to our AHF Africa campaign in the show notes so that you can make a donation if you want, so that we can do more of this. Right now, as an organization, we can only budget 5 doses a month. But you can imagine how difficult this is for Rose, who's leading this initiative on the ground in Kenya, to decide who can receive them when there's so many in need. Rose is overseeing our reach in Kenya and other surrounding countries, and she manages this support program for Rh Immune Globulin doses herself. She actually gets urgent calls from medical centers and mothers and their husbands almost every day for people who need the shot but can't afford it. And she kind of has to triage who needs it most. And if you haven't listened to Rose's story in episode 2, and if you haven't listened to Rose's story in season 2, you need to do that right after this so you can understand just how impactful the global burden of this disease truly is.
Yeah. Lovely. That was so well done, Katie. Yeah. Okay. So why are you laughing?
It's such a weird reaction.
I know. Why? I just turned into I became your teacher. Like you did. That was an A+.
You are a teacher. You were like,
I am not Katie's.
Katie gets a star sticker.
I'm not Katie's teacher.
My sticker chart.
Oh man. Okay. But it is lovely. I'm going to stick with that adjective. It is lovely to know that there are things that we can do to help. And this is not a unsolvable problem, right? So, okay. I think we did it, guys. We packed it in.
We did it.
We did it.
Somehow.
Yeah. Okay. So I'm going to just finish up. You want me to do the sign off?
Do our sign off. Yeah,
okay.
Do it.
Okay. All right. Whether you are a patient, provider, or otherwise affected by antibodies in pregnancy, we are here for you. We have great resources on our website. at allohopefoundation.org. That's allo spelled ALLO, hopefoundation.org. Thanks for listening.
Thanks for listening.
The delay. I can't. Thanks for listening.